Well, our top story today, new figures show the number of people waiting for routine surgery on the NHS could rise to 1 in every 5.
The figure at the moment stands at 1 in 9, with over 6.1 million patients currently waiting for non-urgent treatment. 23,000 of those are waiting more than 2 years, and a handful are waiting up to 3 or 4.
Well, many of the people on the backlog are likely to be in pain and discomfort, with leading physicians warning that prolonged waits could lead to emotional and physical distress.
The figures lay bare the extent of the backlog crisis as COVID infections in the UK remain high, with an estimated 1 in 13 people now infected.
Now, despite NHS leaders saying they're doing all they can to mitigate the crisis, efforts have also been hampered by severe staff shortages right across the health service.
The recent hike in national insurance, which came into force last week, is part of the government's plan to tackle the post-pandemic backlog and is expected to raise £39 billion over the next 3 years.
Well, let's talk to Chris Thomas, who's Senior Principal at the Institute for Public Policy Research and is here. Good to see you this morning.
Good morning.
Look, this is a very disturbing picture, looking as though it's going to get considerably worse. How do we take action now to try and mitigate that?
Well, you're right. The figures are shocking. They speak for themselves. I think the government has to consider a few things. The biggest challenge the NHS faces at the moment is just workforce capacity. There aren't enough people to deliver the care that we need to get through the backlog. There's also a problem with how much we're preventing need at source. So can we do things earlier so people don't have to come in with serious illness to the NHS later? And there is a question of money. We're going to a living with COVID strategy now. That means COVID-19 will become endemic. That has a big resource kind of implication. So there's a question of, do we have enough funding to deal with the resource needs that COVID-19 now introduces as a regular item?
Is it a bit of a postcode lottery as well? Because some regions seem to be coping and others clearly don't. And also different sorts of illnesses and different sorts of treatments.
I think you're right. So what we tend to see is that in some of the more affluent parts of the country, say, where need might be a little bit lower, the NHS might be coping a little bit better. In some parts of the country where maybe deprivation is a little bit higher, we see much higher waiting lists and people struggling to get in. The kind of consequence of that is if people are waiting a very long time, what they're probably going to do, if they can afford to do so, is take their own action, is to use private alternatives and to bypass those waiting lists. And that can create a two-tier system in its own right. So we can see inequalities emerge that way as well.
You talk about almost like a prevention strategy to get at things early. How well funded is the NHS for that? Because we certainly look at the GP situation, but what we don't ever seem to focus on is the pharmacy side. Now, they're a key part of the NHS structure, struggling with funding. Perhaps they could be utilised in a better way.
Yeah, I think that's a great idea. So what we have in the NHS at the moment is still a model that's very rooted in the 20th century. We're quite, the NHS is quite good at very acute emergency care traditionally. What we haven't managed so much is the transition to this kind of modern style of care where people have long-term conditions, chronic need. They might need more regular appointments. And that means more care in the community. That's pharmacists, that's general practitioners, that's care at home. And I think we could be doing a lot more with that to reduce the demand on hospitals and the waiting lists that
you hear
outlined.
this time and again that we don't value our pharmacists enough. They're very highly trained, almost to the medical care level. There's a lot that they could be taking on. I don't know whether they'd want that or how they would be paid, but they are a resource that we don't seem to be using sufficiently.
I think that's right. I think community pharmacists particularly are calling out for more responsibility and for the value that they can add. So I think it's a big opportunity to take pressure off, particularly general practitioners. That's where the big opportunity lies.
It's interesting, isn't it, that through a lot of this, and it's understandable and correct to an extent, that politicians are going to turn around and say, well, a lot of this is down to the pandemic. It's caused so much strain on the system, which it has, there's no doubt. However, this is a problem we've been talking about for decades, actually.
Yeah, I think that's right. So if we look at the pandemic figures, obviously there's been a shock. But if we go back to 2019, waiting lists were on a trajectory to record levels already. So there's something about the approach to healthcare that's been going wrong for a lot longer than that. I think we can look back at the challenges that predate the pandemic. They're the same challenges that exist today. The workforce crisis was a crisis in 2019. Resourcing was a challenge in 2019. Whether we're preventing need was a challenge in 2019. So the same answers that have always been good remain good, and the government can take some plan forward.
A lot of people turn around and then say, well, look, the NHS needs significant reform, changing in the funding model, changing in the usage model. But of course, it's like a sacred cow, isn't it? The minute you try to tamper around the edges, people get very irritated.
Yeah, no government has got the guts to actually tamper too much with the NHS, have they?
Yeah, I mean, I think the principle here is that people still really buy into the kind of founding mission of the NHS. So they want something that's free at the point of use, that's equal, that's universal, that's comprehensive. I think that means that kind of maintaining some aspects of its historic models, so that it's tax funded, that it is free at the point of use, that it's funded by government, remains good. There's still huge potential within there for reform, for changing the way that the workforce works, for bringing in community pharmacy in a way that we haven't in the past, for moving more towards prevention rather than just very, very acute treatment. So there are big things out there for a government with political will that maintain the principles that people like. And that's where I think they have to look.
Where's the private sector playing in all of this? You say a lot of people choose to go private if the waiting lists are huge and they can afford to do so. We were saying before the show, you know, if you go private, the people you see are NHS doctors just working privately on the side.
Often in an NHS hospital.
Yeah, indeed. So what happens for much of private healthcare is that it's someone, you know, that's facing a long wait. They might pay to try to bypass some of that wait. I mean, I wouldn't blame them. I mean, the anxiety or the pain of waiting for care is quite significant. We often don't think about that enough. But you're right, it is the same capacity often that exists in the NHS anyway. So it's not helping get through those waiting lists. It's just reordering some of the queuing system. So, I mean...
But is that a good or a bad thing for the NHS itself? Does it erode the NHS or does it help it?
So I would argue a bad thing. So the problem is that it widens inequalities. It leaves those probably with the most need to wait the longest. I mean, the NHS works best when it's at the point of need because that's the right ordering system in terms of resource allocation. The private sector kind of working tends to be more expensive just overall, and it goes against what people want. I think this is the most important point, that people, even those that are using private services, aren't doing so because they really want to. They're doing it because the government hasn't created an NHS that's good enough. That's what they want.
So what's the answer then? Is more money for the NHS, really, and more recruitment?
Yeah, some of it has to be about more money, but it can't all be about more money, can it? So there has to be...
No, because we always argue, don't we, that it's a bottomless pit.
Yeah, exactly. So I think, you know, we do have to account COVID-19 is a regular... And, you know, it will move to an endemic. It will have a consistent level of new demand that the NHS hasn't had to cope with before. So that justifies more funding, just to kind of maintain supply in the way that it's always worked. But I think there's huge potential that we can think about in terms of reform. We can think about how the workforce works. We can think about what innovation is out there. The UK as a country compared to, say, France or the continent is not very good at the spread of innovation. We find it very hard to get it not necessarily into some parts of the country, but the whole country consistently.
There's been a lot of criticism about the national insurance hike because people can't afford it at the minute, which is absolutely understandable. £39 billion it will raise over however many years it is. I don't know now. But we hear that the inflation rate, as it goes up, has in effect wiped that out already.
Yeah.
Now, so if the NHS was expecting that money, it ain't going to get it.
But it means if there wasn't the insurance hike that people can't afford to pay, we'd be in an even worse position.
Yeah.
Which is, I mean, it's like the perfect storm, isn't it?
Yeah, and I think there'll be lots of people today working in local NHS trusts, CEOs, directors of finance, that are saying, look, what I was expecting to happen, the thing that I'd made my care plans on at a time that, you know, waiting lists are very high, that demand is very high, that accident and emergency is struggling, ambulances aren't getting to people. They're saying, look, the cost of living crisis, the inflation, the extra costs I bear mean that I can't make ends meet. And that will have tangible consequences for people trying to get their care.
We always hear our politicians say it, and we believe it, we've heard it so much, that the NHS is the best care system in the world. Is it?
So what tends to happen with the NHS is that I think the principles that sit behind it are the best principles in the world for a healthcare system. Are the outcomes the best? No. And I think the British public are very clear that it's a people's priority for health outcomes to be the best. We at IPPR looked back at polling since the 1980s. What we found was that consistently the NHS has been the number one issue for the general public. So they really want it to be the best. So I think what we need to do is we need to say, OK, we understand that the principles behind it can work. We see that it can work because in some parts of the country, the NHS is fantastic. It's not that it's kind of bad everywhere, it's just inconsistent. And what needs to happen is political commitment to making that the case everywhere. That's the real challenge ahead of us.
OK. Chris Thomas, really good to talk to you this morning. Thank you very much indeed. It's interesting, isn't it, I think, in all of it. And it's like with the national insurance hike that people don't want, a lot of campaigning against, and a lot of people obviously just can't afford to pay. And yet it's the same people who then say, we need to be investing more, we need to be paying nurses more. But it's like, well, then we've got to pay for it. I think sometimes we all just need a really big dose of cold reality with these sort of things. If we want better, we've got to pay for it.
Yeah, I mean, it is a wonderful principle, the idea that healthcare for all at the point of need is the most brilliant principle, but it's a very expensive one. And other countries don't even go anywhere near it.
No, and the thing is that the remit of the NHS has changed so much since it was brought about, hasn't it? And you look at your long-term healthcare. I mean, look, my cost to the NHS will be astronomical.
Yeah, your
I
cost
should think.
a fortune.
I cost a fortune.
And that's where there were always those arguments like, is IVF something that the NHS should be providing, or is that a choice, and a very expensive choice indeed, that should be made privately? There are all sorts of arguments like that.
What do you think about that? Because I'm not a parent, and I have to say I always find the IVF thing, and I know people who've had it and they're desperate for families and all the rest of it, and I sympathise, I really do, but I struggle with that as a funding
Cosmetic
issue.
surgery. When I say cosmetic, I mean, something that needs doing because it is affecting your life, but it is actually still cosmetic surgery. Should that be available on the NHS?
Yeah, the bariatric stuff,
surgery,
which is weight loss surgery.
But it's about maintaining life and preserving life. Bariatric surgery often, so, you could argue that should be available on the NHS, and is. But just where do you stop, I suppose? That's always the question with the NHS.
Interesting, isn't it? It's why it's a bottomless pit.
Yeah, and it is nevertheless why we're so proud of it.
Yeah.
Absolutely wonderful.
Oh, your views on that would be very welcome today if you would. gbviews@gbnews.uk.